cut, or it's going to lead to soft tissue balancing. So here in this top photo, you can see that we're resecting the osteophytes. I'm doing a chylectomy. And then what I like to do when I measure out how deep my cut is going to be on my proximal phalanx, right? I have the bovie right here, and then atop that, I have the implant, and I'm just measuring out the width of the implant, and that's going to make a little mark there, and that's where I'm going to make my cut. And when you're talking with orthopedic surgeons, just tell them that you want this cut, which I'm showing in this top picture here, that you want it to be much like when you're cutting for your tibial tray, when you're doing your cut off the tibia, and particularly in the lateral part of the tibia. And they're going to know what that means, meaning you almost want to see the saw blade as you're coming through the inferior surface. Less is more. So if they take less and they need to take a little bit more because they feel the joint's too tight, they can always take more, but you don't want them to make too big of a cut. You size the implant, and they really want to make sure that the implant sits on the end all the way around the cortical bone of the proximal phalanx.
How does that work?
The next key point is that we don't want to place the drill hole. When you see this here with the K-wire, and the drill hole, what you do is you place your K-wire, so you use your sizer, and you place your K-wire through, and if anything, you want to cheat that just a little bit dorsal, not plantar. And the reason is if you place it too plantar, then what happens is they can end up cracking through the plantar cortex of the proximal phalanx, okay? So then you want to size it and check the motion. And then here's why I said bring two. So you see right here in this photo, I built a nest, and you see I have an extra half sheet underneath here and some towels where I build a nest, because when I go to put the implant in, you're pushing down with your thumb, and once I had one of these, I was really pushing down because I had some pretty rigid subcortical bone that I was pushing in and pushing in and pushing in, and I pushed, and then boop, it went out on the floor, and the rep said, "Oh gosh, I don't have another one with me." And I said, I had actually had a couple extras in my locker, and I said, go in my locker. I have a size 21 in my locker. And and so have them build a nest and always bring two. So you can see here, here's my thumb. I'm pushing it in, and again, I like to make a minimal resection and have some really nice stout subchondral bone that I can put this implant into, because this implant is not a ingrowth type of implant. It's not going to be stable unless you're putting it in to some pretty solid bone. And then I use the impactor. And then you check your range of motion afterwards. And if you need to perform more of a chylectomy, that means taking a little bit of bone off the dorsal surface of the first metatarsal head, you do so. And then here's a couple examples of what it looks like. And that's it. Any questions?
Anybody have any questions for Dr. Giza before he has to get to a case? There's one question, Dr. Giza.
Absolutely.
I have docs that believe that resecting the phalangeal head and inserting hemi does not address the problem. Any suggestions how to combat this?
Yeah. I think that there are a lot of people who feel that the arthritic portion of hallux rigidus is secondary to degenerative change that starts in the dorsocentral portion of the metatarsal head. This may be from a repetitive trauma or whatnot. And I truly believe that as well. I mean, I've had a couple of acute injuries in ballet dancers and some beach volleyball players out here in California where they actually have an injury where they hyperdorsiflex and they knock off a piece of cartilage in that dorsal central portion. And in my mind, I think that that's the start of their hallux rigidus that they're going to come and complain to somebody else about, years later. So when you have someone who has a grade 2 hallux rigidus and they have some joint space narrowing, typically when you look inside the joint, they really don't have much degenerative change on the side of the proximal phalanx. And that's why I tend to lean more towards doing a chylectomy, removing that arthritic portion of the metatarsal head on the dorsal central portion, as long as there's well-preserved cartilage on the remainder of the metatarsal head and proximal phalanx. At the same time, when you get into someone who truly has grade 3 and grade 4 hallux rigidus, it really doesn't matter because both sides of the joint are arthritic. And what you can always tell these doctors is, listen, hemiarthroplasties in the hip work, even in patients who have some hip arthritis. If you have an 85-year-old patient and they break their hip and you put in a hemi, they do pretty darn well. And it's the same idea, is that you are creating a spacer, you're not creating a total toe, and you really want to be able to maintain their motion and allow them to regain a normal gait pattern. There is some, obviously I've tried. There's a metatarsal head resurfacing implant, and that I think is really something that should be reserved more for AVN of the metatarsal head, which is quite rare, or if you have someone who has a degenerative process that's mostly on the side of the metatarsal head. So if you have people out there who are doing this procedure in a young patient who really should just have a chylectomy and most of their joint looks pretty good, it's probably not the best operation. They could get a chylectomy and have another 5-8 years out of their joint before they'd have continued degeneration. So probably the best way to combat that is to kind of ask them, well, are you really making sure you have the right indications? Because by the time anybody has grade 3 and grade 4 hallux rigidus, they're certainly going to have degenerative changes on both sides of the joint.
Excellent.
There's one other question about the reamers. Do you try to ream a lot to prepare that proximal phalanx? Or
I don't. I'm a freehand cut guy. I like to do just like I showed you. They certainly do have the reamers, and now the reamers are nicely done with that little curve in them so that you can get it past the metatarsal head without scratching the metatarsal head too much. So typically what I'll do is I'll make my cut, and if I feel that it's not perfectly even, I will do a little bit of reaming. But I don't use the reamer primarily. I rely more on my cut and my judgment so that I can make sure I really balance out the soft tissues.
Check that, but I would probably say...
Does anybody else have any questions for Dr.
I see there's one percentage of cases that convert to fusion later on. And I would tell you that so far, I've been in practice 6 years now. I've had one that I've had to take, that it basically subsided, and I've had to take out and then convert to a fusion. And the other thing to make clear to your surgeons is that if they're doing this in the correct patient population who otherwise would go elsewhere and get a first MTP fusion, you can say, as long as you're making a minimal bone resection in the proximal phalanx and doing this correctly, you're not burning any bridges. They can come back and take this out and then perform a first MTP fusion without shortening the first toe and the first ray considerably. And that's why I think this is really a pretty reasonable option as long as patients do understand that there is a possibility that this could fail because it's not a porous ingrowth implant and it acts as a spacer. But that's typically what I tell patients and what you probably can tell other folks.
Dr. Giza, we appreciate your time. I know you're busy and probably late for your case, but appreciate it. It's very helpful for the reps.
Happy to be here, and thanks to everybody. Have a good holiday.
Okay, you too.
You too.
Take care. Bye-bye.
Bye-bye, guys.
Okay, thanks, Dr. Schoen.
Take care. Great talk. Ciao.
Hey, one more quick talk from Dr. Dorrell.
Great. Well, thanks, guys, for staying on. I'm not Dr. Ciccanelli, but we will cover trimmet screws as best as we can this evening and try to go through some of the features and benefits and some of the slides that he passed along. Unfortunately, he couldn't be here coming back in the country from Spain. But looking at trimmet screws, why sell it now? These screws mechanically are better than metal. Metal is stiffer than bone, but absorbable screws are roughly equal, and it gives us a better marriage between the bone and the implant. The difference between these two screws, bio and metal, is stress sharing versus stress shielding. Just stress sharing from bio screws versus the shielding of metal. And these screws work. You can put them anywhere you place a metal screw and not have to worry about removal. Patient acceptance is great. Patients and surgeons